If you've seen the viral videos and news articles about Pepcid plus Claritin clearing brain fog, hot flashes, etc., and you've been wondering what the heck is this even about? What is the evidence behind this? How does it work, etc.? Well, in the next 35 minutes or so, I am going to walk you through the literature and the evidence, who this combination might actually help, and the safety conversations no one is talking about. Hi, I am Dr. Shad Abdulla. I'm a naturopathic doctor, and I built Blue Arrow because I want to share my naturopathic doctor training and knowledge so that people who aren't getting answers from their conventional doctor can find the answers with me. Today, I am talking about the Pepcid plus Claritin perimenopause trend. And by the end of this episode, you will know 3 things. 1, the actual estrogen and mast cell biology that makes this combination plausible for some women. 2, a 5-symptom screen that helps you tell whether the histamine angle is even worth exploring for you versus whether you are chasing the wrong lever here. And 3, the safety conversation and the HRT interaction questions that the news articles have been skipping. So stay with me. This is not just a hack piece. This is the framework piece that will hopefully make you understand this better. If you're interested in learning more about this, you can check out my website at bluearrow.org. So save them or come back to them after this episode. If you've been told that your labs are normal, but you know something is off, if you have noticed that wine that you used to drink now flushes you for an hour or so, if your cycle now comes with a wave of anxiety that lifts the day you bleed, and if you woke up 3 in the morning, wired and hot, itchy, and you have no idea why, then this episode is definitely for you, because the trend you have been seeing all over your feed has a real biology underneath it. And you deserve to understand it before you decide what to do. Now, let me back up a little bit. In the last few weeks, the news cycles like CNN, ABC, and a long list of outlets ran the same articles, a combination of over-the-counter H1 histamines, things like Claritin, Allegra, Zyrtec plus famotidine, which is a Pepcid, went viral as a premenopause hack. The original signal actually came out of a PMDD community a couple of years back. And then, there was a thread post about brain fog clearing in days. It went viral. And then the press picked it up. So the press did what it does. They asked an OBGYN if there were evidence behind this, and they said no. And that's where the article ended with "talk to your doctor," and the audience was left with nothing useful, really. And I think that's where the gap really is. The audience is not asking for permission. They're asking for a framework. But here's the thing, actually, that biology is real. It's just not the biology the trend is describing. So I want to give you the mechanism in one clean line, and then I am going to unpack it. Estradiol activates mast cells via the ER alpha and lowers DAO. That's the enzyme that clears histamine. So a sentence right there is doing a lot of work, so let me slow it down and explain a little bit more. Histamine is not just an allergy chemical. It's a neurotransmitter. And mast cells are immune cells that sit inside almost every tissue in your body. So like skin, gut, blood vessels, brain, uterus, bladder, etc. Now, they were originally identified for their role in allergy because they are full of preformed sacs or granules of histamine, and they release that histamine when their receptors get cross-linked by an allergic stimulus. But that is the narrowest possible view of what mast cells actually do. Now, over the last 20 years, the literature has widened that view considerably. Mast cells respond to hormones, neuropeptides, to physical triggers like temperature and pressure, to stress hormones, and a long list of other inputs that have nothing to do with allergies. Now, when they get the signal to fire, they release what I call a soup of inflammatory mediators, and the loudest one in that group is histamine. There's other things like tryptase, prostaglandins, cytokines, heparin, but histamine is the one with the most familiar quote unquote fingerprint that we know. Or rather, what we usually talk about with allergies. Histamine itself has 4 known receptors in the human body. So H1 is the one you think of for allergy. H1 receptors are on smooth muscle, blood vessels, and nerves. They drive that itch and they dilate the vessels. They cause bronchospasms. And then H2 receptors are concentrated in the stomach where they drive acid production. That is why famotidine is sold over the counter for reflux. It blocks H2. H3 and 4 are less commercially relevant, but they show up in the brain and on other immune cells. Now, the thing that gets lost in the allergy framing is that histamine in your central nervous system is a wake-promoting neurotransmitter. It is one of the molecules your brainstem uses to keep you alert. It influences mood, gut motility, blood vessel, and stomach acid. So when mast cells get reactive systematically, you do not just feel, itchy, you feel everything. Edgy, hot, wired, wakeful at 2, 3 a.m., reactive to a glass of wine you used to drink without thinking. That is the clinical picture I want you to hold on to when I say histamine pattern symptoms. Now, estrogen, specifically estradiol, has receptors on mast cells, and the most studied one is estrogen receptor alpha. When estradiol binds that receptor, mast cells become more reactive. They fire more easily and release more histamine in response to other triggers. That is from Zaitsu in 2007, a paper that used cells from estrogen receptor alpha knockout mice, and the knockout cells did not respond to estradiol. The wild type cells did. Now, this is one of the cleanest evidence in the literature that estrogen, through this specific receptor, directly turns the dial up on mast cell reactivity. Now, here's the part that perimenopause makes interesting. Progesterone does the opposite. Progesterone stabilizes mast cells. And an article by Vaziadi in 2006 showed that progesterone at physiological concentrations inhibits histamine secretion from mast cells in a model that uses several different triggers. So progesterone calms the system and it usually revs it up. In perimenopause, progesterone tends to drop first, years before periods even stop. So ovulation becomes less reliable, and the progesterone you used to make in the second half of your cycle starts decreasing more and more. Estrogen, meanwhile, does not glide down as fast. It oscillates really quickly. It can surge, sometimes higher than it was in your reproductive years, and then crash really hard. So you can have windows of relative estrogen excess in a body that has lost its progesterone break. The mast cells fire and the DAO is down, and your tissues see more histamine more often. This is the part that almost never gets translated into the news articles. The perimenopause is not just less estrogen, it is erratic estrogen plus declining progesterone. That asymmetry is what gives the histamine axis a new opening that it did not have in your 20s. Women I have talked to often describe it as their tolerance changing. The same glass of wine, the same aged cheese, same handful of leftovers. Things that were neutral are now reactive. That is the shape of the system shifting under your feet. And the timing tracks the PMDD literature, which Dr. Jolene, Brighton, and others have written about for years, describes a luteal phase spike in mast cell activation symptoms. The luteal phase is when estrogen is supposed to be lower and progesterone is supposed to be higher. But in many women approaching perimenopause, that's exactly when the progesterone break fails first. The result is a cycle where the second half feels worse than it used to. And the relief comes when bleeding starts and the cycle resets. Now, this is well documented in mechanistic papers, and it's the reason the trend is not totally absurd. But here's where the trend does go wrong, and this is the part the news article missed completely. The trend's biggest claim is that this combination helps hot flashes, and hot flashes are not driven by peripheral histamines. Hot flashes are driven by a cluster of neurons in your hypothalamus. There is a group of neurons in your arcuate nucleus called KNDY neurons. The same comes from the three peptides they release: kisspeptin, neurokinin B, and dynorphin. When estrogen withdraws, those neurons hypertrophy. They get bigger, more reactive, and they sit right next to the thermoregulatory center in your hypothalamus. When they fire, your body misreads its temperature and triggers the cascade that becomes a hot flash. Vasodilation, sweating, and the wave that climbs up your chest. Now, the reason this is identified as the dominant mechanism comes down to a drug called fezolinetant. Fezolinetant is a neurokinin 3 receptor antagonist. It blocks one of the KNDY peptides at its receptor. In the Skylight Phase 3 trial in 2023, fezolinetant cut hot flashes frequently by roughly around 60%. That is the number I want you to hold on to here. Now, peripheral antihistamine cannot get to those neurons in a way that touches that mechanism. So if the only reason you are considering this hack is hot flashes, the literature is telling you this angle is wrong. There is a study I want to flag specifically because it is small and old and almost never gets cited in the trend coverage, but I think it matters here. The Calogermitros, I hope I said that name correctly, and colleagues published a study in the Annals of Internal Medicine in 1976. They gave estrogen to women with hot flashes, and they measured histamine turnover. The estrogen relieved the hot flashes, and the histamine turnover did not change. Now, that is direct human evidence that the hot flash relief from estrogen is not happening through the histamine system. It is happening more upstream in the hypothalamus. That's one of the cleaner countermechanism data point the trend has to contend with, and almost nobody is naming it, I feel like. Now, what if your symptom cluster is not actually hot flashes? What if it's the food reaction and the itchy scalp and rosacea flush and the 2 a.m. wake up and the cycle correlated rage? That is a different story, and that is what segment 2 is going to be about. So the 5 symptom screen, the phenotype I think is worth taking seriously, and the part of this that the body is saying out loud. Here's what I have come to think about this drug. The women who post the viral testimonials are definitely not lying, and some of them really do feel transformed in, let's say, 3 days. And some of them are responding to a real receptor blockade in a body that was being driven by histamine signaling. And some of them are responding to the same expectancy effect that drives the placebo arm of every hot flash trial. And both can be true in this case. I want to name something else before diving deeper. $15 of over-the-counter medication is not exactly a hack. It is what happens when women cannot afford or access hormone therapy, when their specialty appointments are 6 months out, when their primary care visits was 15 minutes and ended with a talk to your gynecologist. That is not the women's fault. That is what happens when a clinical gap stays open long enough that women fill it themselves. So when I talk about this trend, I'm not talking down to anyone who tried it. I am trying to give you the framework that should have come with a conversation in the first place. So I want to give you a way to tell the difference, not a perfect way. There's no validated way, unfortunately, and there's no blood test that can tell you with certainty that you are a histamine pattern responder. The DAO testing is sold all over the internet, and I want to say this plainly. The 2020 state-of-the-art review of it on histamine intolerance concluded that DAO testing is not as reliable by itself as a tool for diagnosis. Levels swing day to day. They do not correlate cleanly with the symptoms exactly. So if a lab is telling you this panel and telling you it confirms histamine intolerance, what they're telling you is a number, not exactly the answer. What I trust more than the lab is the symptom pattern in these cases. Think about it this way. A DAO level is like an hemoglobin A1C. It is an average. It tells you something at the population level, but it does not tell you what is happening in your specific body on a specific Tuesday in your luteal phase. The signal that actually matters is whether your symptom cluster in a histamine pattern. The cluster carries more diagnostic information than the lab. So here's the screen, the 5 symptoms. If you have 3 or more, the histamine angle is pretty worth exploring with a clinician who knows the literature pretty well. If you have 1 or 2, that picture may be mixed, and there are other things you should probably take a look at first. Now, if you have 0, it may not be as likely that you have a histamine overload. So symptom 1, new food reactions. For example, reaction to wines, aged cheese, leftovers, fermented foods, chocolates, things that used to be fine, but now flush you, makes you itchy, bloat, or gives you headaches. These foods are all either high in the histamine themselves or they release histamine in your gut. And the reason the food reaction matters as a signal is that they tell you something about your DAO capacity. DAO is the enzyme in your gut lining that breaks down histamine before it gets to your circulation. So when DAO is down, a glass of wine that used to be neutral now reads as a histamine load your body cannot keep up with. So if your reactions are new in the last, let's say, 6 to 12 month-ish, and they are usually clustered around the foods that are, and they cluster around the foods that load histamine, then this pattern is definitely worth keeping track of. Symptom number 2, A flushing or rosacea pattern. I'm not talking about the brief hot flash wave that climbs your chest and goes away. I'm talking about a longer flush of the cheeks, neck, or chest, often tied to food, heat, alcohol, stress. If your face has started looking like you ran a mile when you did not, then that's a symptom to keep track of. Symptom number 3, hives, itching, or burning skin, random hives. Their scalp is itchy for no reason, skin that feels like it is sunburned when you did not go. Histamine on its skin receptor is itch. If your skin is acting up in a way it never did before, that is a signal. Now, symptom 4, a cycle-correlated mood crash. So anxiety, irritability, intrusive thoughts that show up in the luteal phase, the second half of your cycle. And they peak and then they lift the day you start your period. Now, this is the PMDD overlap, and this is the symptom where the histamine literature is loudest. Histamine is a neurotransmitter that interacts with estrogen, and women in luteal phase with relative estrogen excess can have mood symptoms that track the histamine axis. The reason this matters on a screen item is that it gives you a built-in test. If your mood symptoms generally lift the day you bleed, the symptoms is hormone modulated. If they do not, the histamine axis is less likely to be the dominant driver. Symptom 5, histamine pattern insomnia. And this is the one I want you to pay attention to because the pattern is very specific here. So falling asleep is not exactly the issue here. The problem is waking up like around 1, 2 to 4 a.m. You feel wired, you feel hot and itchy. So histamine is a wake-promoting neurotransmitter. When mast cells fire in the middle of the night, you wake up. The pattern is not the I'm stressed and my brain will not stop. It is the I was sleeping and then suddenly my body turned on. My body just turned on. Some women describe their skin getting hot maybe. Some describe as an itchy in a specific spot. Some just describe wakefulness with a quality of physiological alertness that does not match how tired they are. Now, 3 or more, the histamine angle is definitely worth taking seriously and tracking your symptoms, especially for a while. So like at least 4 weeks. Write them down. Note what foods you've eaten, what triggers you, what you were, where you were in your cycle, what your sleep looked like, and bring that data to your clinician. 1 or 2, the picture is mixed and other physiology is probably the lead driver. So look at things like your thyroid, ferritin, cortisol pattern, and whether you are a candidate for HRT, so hormone replacement therapy. Now, I want to read you the caveat that goes with this screen because it is the most important part. Response to a drug is not a diagnosis. Feeling better on antihistamine does not mean you have histamine intolerance or mast cell activation syndrome specifically. It means the receptor blockade quieted a downstream signal. The framework I just walked you through is a clinical screen, not a label. So keep that distinction. It will keep you out of trouble in the wellness diagnostic economy. And here's one thing that I want to bring back and have you sit with this information for a hot second. Hot flashes are driven by hypothalamic KNDY neurons, which is why fazolinetant cuts them about 60%. If your dominant symptom is the climbing, sweating vasomotor wave, the literature is telling you which receptor population to target. And it is not in your gut specifically. It's in the hypothalamus. The drug that addresses that mechanism is either hormone replacement or another drug like vasolentin. Now, there are other herbs that can help with this, other alternative naturopathic ways, but in this episode, just to keep things a little bit short and focused on mechanism, I will not mention them specifically, but in future, I will definitely bring them up. Now, if your dominant symptom are the food reactions, the flush, the itch, the cycle-correlated moods, and the histamine pattern wake up, then the trend you're seeing is targeting a receptor population that might actually be doing something in your body. And here is what I want you to walk away with. The estrogen mast cell biology is definitely real. The trend is not exactly a hack and it's not exactly a miracle. It's a downstream lever that might genuinely help a subset of perimenopausal women whose symptom cluster sits in the histamine pattern. For women whose dominant symptom is the true vasomotor hot flashes, the literature is pointing somewhere else. So hormone therapy, if you're a candidate, vasolentin, if you're not, those are the mechanisms that match the biology. What I do not want is for you to walk out of this episode with a prescription pad in your hand, and I did not give you doses on purpose. I did not give you a daily protocol on purpose. The reason is that the right next step for you depends on which of the 5 symptom buckets you sit in and what other medications you are on. Whether you are a candidate for HRT and what is going on with your thyroid, ferritin, your B12, how is your sleep. So none of that fits into a $15 over-the-counter drug that you can buy and hope that it will fix everything for you. I also want to say this for those of you who are listening to this podcast. You guys are intelligent and you're tired of being dismissed by both the influencer wellness world and the dismissive end of conventional medicine. You did not come here for permission. You came here for a translation of what is going on. So my job is to translate the literature as honestly as I can and to give you the framework that lets you make a better decision than you would have made without. So your homework this week, take 4 weeks of symptom data. Use a simple note app on your phone. Make a 3 columns, date, symptoms, what was happening. Write down what you were eating, where you were in your cycle. If you still have one, 4 weeks of that data is more useful than spending money and getting a DAO test. Now, that test may be helpful in the future, but when you're first starting out, having a really thorough symptom history is a lot more useful. All right, and as always, this content is for educational purposes only and is not medical advice. So please talk with your healthcare provider for individual recommendations. The Pepcid plus Claritin question is one that definitely deserves a clinician who knows both the mast cell literature and your full medical history. And if you found this useful, the best thing you can do is share it with someone in your life who has been told her symptoms are just stress. That is how this work spreads, and I will see you in the next episode. Thank you so much for being here.